Good morning, everyone. Today we have with us Dr. Ibrahim Abugheida. He'll be discussing with us about managing patient with bone and distance metastasis. Welcome on board, Dr. Abu.
Hello, how are you?
All good, sir. How are you?
Good, thank you.
Uh, Dr. Ibrahim is head of radiation oncology at Burjeel Medical City, Abu Dhabi. He is trained from world-renowned cancer institutions, including American University of Beirut, Cleveland Clinic, Ohio, and the University of Texas MD Anderson Cancer Center. Dr. Ibrahim has special interest in treating breast cancers, gastrointestinal cancers, genitourinary cancers, thoracic and central nervous system diseases, as well as benign and functional diseases amenable to radiotherapy. He's a member of American Society for Radiation and Clinical Oncology. So we will look to ask from you that what is basically bone and distant metastasis, and what is the main cause of these metastasis?
Thank you so much for your question and for this very nice and kind introduction. So there are different types of cancer, and there are some cancer that are, likely to spread out rather than being in a certain location. And usually when cancer spreads to a distant site, meaning away from its origin site, this is called distant metastasis. The spreading usually happens through the blood streams or through the lymphatic drainage of the primary site where the cancer is originating from. So this is in general about distant metastasis. When the cancer cells goes through the blood and find like a certain bone where it's kind of sets and start formulating a colony of cancer cells, or hence forming a tumor, this is when the cancer spreads into the bone. So there are some cancer that goes to the bone, there are some cancer that goes to the brain, some cancer goes to the liver, but in terms of, they are all called as distant metastasis because the cancer has spread out from its original site and found a different place where it metastasized.
Okay, so related to this, what are the medical complications we face or the patient with bone metastasis face?
So the complications ranges some bone metastasis the patients have, and they are completely asymptomatic, meaning that they don't have any symptoms, and it's just found on scanning. There are sometimes when you have a bone metastasis that is causing some pain, meaning that the tumor that is formulating in the bone has displaced a lot of normal bone and has of course some compression on small nerves and causing some pain. There is some areas where the tumor is so extensive that it actually causes the bone to break, causing what we call a pathological fracture, which it fractures from the tumor. There are some areas where the tumor, it start compressing other organs next to the bone that causes pain as well, like the spinal cord. If you have a tumor that goes to the spinal or vertebral column and starts growing inwards, compressing the spinal cord, it can cause some neurological symptoms. And so on and so forth. So it really depends on which bone, but I would say the most common symptom of bone metastasis is pain. If it shows, patient usually reports with pain.
So basically, what are the types of cancer most likely in which normally bone metastasis is seen?
That's a very good question. So it depends. So there's a lot of cancers that I would say they like to go to bones, but that doesn't mean that other cancers can't go to bones actually. So because it's just like, the mechanism of action, how do cancer spread? I would say breast cancer, because it's the most common cancer that we see. So hence the number one reason where patients we have with bone metastasis are usually from breast primary or breast cancer primary. Lung cancer also has a tendency to spread to bones. Prostate cancer in men also has a high tendency to spread to bones, and so on many other cancers like head and neck cancers, gynecological malignancies. So it really doesn't matter, what type of disease it originates from. It matters on finding the nice medium to grow and cause symptoms inside the bone.
Okay, so sir, if we talk about diagnosing the metastasis, so what are the basic test, or what are the basic evaluation which is required or used for the diagnosis?
So the first of all is the most important test is the history and physical exam. So we need to take a detailed history from the patient, discuss about this pain, try to identify what type of pain it is. Is it suggestive of metastasis or not? Physical exam is extremely important. And then we go to the more further testing and imaging. Sometimes plain X-rays can show us, extensive disease. Sometimes we see the bone metastasis on cross-sectional imaging, like as CT scans or CAT scans, or PET scans as well. And sometimes we use bone-specific scans, like as bone scans, that can also help us to see bone disease as well. So there are multiple imaging, and the ultimate way of diagnosing bone metastasis is actually by having a biopsy of this to prove that this is actually cancer-related growth, not something else. So it ranges from history, physical exam, all the way to the biopsy, which is always the gold standard. If, of course, it has to be a safe biopsy, which is always the gold standard in diagnosing.
Okay, so if we talk about the prognosis, how it takes place basically in bone as well as in distant metastasis of different parts of the body. So how is the prognosis of this?
Well, if you asked me this question 10 years ago, I will have a different answer than the answer now. So there is, so usually when we have bone metastasis, this is automatically stage 4, but we think, stage 4 is a bad prognosis for the patients. However, we have to keep in mind that now metastasis is not all the same. There is a new entity in oncology, what we call oligometastatic, which is metastasis that is limited metastasis. And we believe that these patients have a different biology tumors than the ones that are diffusely metastatic. And having a bone-only metastasis as compared to bone, liver, and brain metastasis, it's also a completely different outcome for the patients. So in general, we tell the patient, this is stage 4. This is most likely an incurable disease. But now with the development of very good drugs and treatments like immunotherapy that can give us long-term outcome in these patients, we might be able to actually give them a better quality of life, better control of the disease by sometimes treating those metastatic sites if they are limited and they are able to be treated easily. And so we cannot group them all in one group. So the outcome really differs between one patient, let's say a prostate cancer patient with 1 or 2 bone metastases, and a lung cancer patient with 5 bone metastases, 2 liver lesions, and 1 brain lesion. So these are both metastatic, but the outcome is completely different.
Okay, so now I'm coming to the most important part of the discussion. So what role does radiation therapy plays in such cases?
Yeah, thank you so much for that. So radiation is actually a very powerful way on killing or controlling cancer cells. So radiotherapy in the form of, metastasis, sometimes we have a big role in kind of, so as I mentioned, sometimes the bone metastasis causes some pain and the patients are using a lot of pain medications. And we know that there's a focal area that is causing severe pain and the patient is having significant side effects from the pain medications, including the constipation, dizziness, etc. Or he or she cannot tolerate the pain medication. Sometimes we resort to radiotherapy to try to control the pain in the patients. So of course, the degree of control varies between patient and the other, between the biology of the tumor, between the type of the tumor. And sometimes radiation is actually used more aggressively, I would say, for patients who have limited bone metastasis. After we make sure that we have good systemic control, they are giving good drugs and they are stable, then we say, can we treat those with a slightly higher dose or with an ablative dose that could kind of give us local control. And there are actually very encouraging phase 2 data that supports that for different etiologies. I would say the most important trial is the Saber Comment trial that came out from Canada that have actually really shown an improved progression-free survival in these patients, meaning that these patients are less to progress when they are offered more aggressive local therapy with radiation, of course.
Okay, so if we talk about why Burjeel Medical City for treatment, so what are the advancements which are there because of which a patient should consider Burjeel as an option for treatment?
Well, thank you so much for this question. Again, that's a very I would say hard and honest question. Like, so I would tell you why us. I would say everyone who practices oncology practices for a purpose and practices to try to give the best for their patients. But what I can tell everyone listening and seeing this is that here in Burji Medical City, in Abu Dhabi, actually, I tell every patient that I see that we are treating as if you're our own family. So we treat patients as if they are our own family. We put ourselves, our shoes, in terms of in the patient's self shoes or their family shoes. We respect the culture, we respect the identity of the patient, and most importantly is that a lot of times, we tell patients, no, you don't need treatment. You need to go back home and stay with your family. So it's a very fine balance between over treating patients and even with the intention of doing the best for the patient. So it's always important that we balance this, and I would tell them, every patient that gets seen and treated here, look at them, and it's not only for me. I tell this to the nurses, to the therapists, to the staff, to the physics team. If this is your own family member, what will be your treatment option for this patient? And this is how we minimize errors.
So basically, it is not a treatment; it is personalized care experience.
Absolutely. So it's individualized. It's the treatment, and we have to individualize treatment. We have to be so radiation is all about accuracy, and it's all about precision medicine. It's all about how can we find something, how can we integrate. A good radiation oncologist is not only a good radiation. A good radiation oncologist is a good medical oncologist, a good surgeon. So how can we integrate the multidisciplinary approach for these patients? So if I'm treating something and I know that there might be an immunotherapy that might help me improve the patient's outcome, then we should definitely have the medical oncologist's input in that. So the good thing about this ecosystem in treating patients in a comprehensive cancer network is that it's not a single person that's taking care of a patient. It's a team, and it's all about. I always emphasize it's the team that matters. So it's individualized, personalized, tailored treatment that suits every single case.
Okay, Doctor, if we talk about the protocols and guidelines, what protocols and guidelines are you using to provide them with the best treatment?
Yes, thank you so much for this. So the currently accepted protocols and guidelines that is mostly adopted worldwide is the NCCN guidelines for treatment of cancers. Okay. On top of that, so the NCCN guidelines have also some details about radiotherapy in terms of those constraints, etc. But to be very honest, I think we can do better. So the NCCN guidelines is placed for the entire world to look at it. But coming from some centers that I know that we can deliver a better plan. And for example, I'll tell you about a very common scenario: breast cancer. Okay, so breast cancer, when we're treating breast cancer, the NCCN guidelines give you, or the RTOG guidelines give you, a certain heart tolerance dose. For the heart, you have a certain tolerance dose. And I think this dose can be really lower, and with the techniques that we have at Burji Medical City. So that's why, for example, we are doing gated treatment. So we are taking the patients are getting their treatment while having a deep breath. And this actually saves a lot of the heart, decrease the dose on the lungs as well. So decrease the potential late side effects of radiotherapy. This is extremely important. So actually, we sometimes I aim for a mean heart dose of less than 2 gray or less than 1 gray in some cases, rather than 4 gray, which is usually accepted. So we always try to do the extra step that might really save the patient's long-term consequences.
And that might help patient as well, because they don't have to go for the extensive treatment, which definitely brings on with many side effects with that for the patients.
You're absolutely correct. I was trying to do the most cost-effective, patient-driven treatment. If we know that if we can deliver treatment in a shorter course that has the same efficacy and even sometimes better than the long course, this will be our option. And I gotta say, despite all the bad side effects of COVID and the problems with COVID that are created worldwide, actually, COVID have highlighted the importance of, do we really need to get the patients 6 weeks for radiotherapy, Or can we get them 4 weeks? Can we get them 1 week for radiotherapy? So that doesn't mean that every patient has to come and spend 3 months of their time, of their time that they want to spend with their families back home away. No, we can actually deliver the same treatment, sometimes even more effective, in a shorter period of time. And all you need is the will, the experience, the machine that does that, and very importantly, the physics team who behind the scenes do all the quality assurance of the machine, who is confident and experienced enough in commissioning this kind of treatments.
And that brings out with the best results for these patients as well.
Yes, inshallah. Yes, that's always our aim.
Yeah. All right, doctor, this was it. So I think the discussion which we had will really help out many of the cancer patients who seek treatment for bone and distance metastasis, and how they should, follow the path of the treatment. So this will really help them out. And I'm really thankful for you for providing me with the valuable time from your busy schedule. So thanks a lot,
No
sir.
problem. Thank you so much for your time. And again, we are here to help. I mean, we studied medicine to help people. I mean, our job is to help people, and our busy schedule is because we have people we're trying to help. So our job is to convey this message, and our numbers, our contact details. Please feel free to share them with
Sure, sir. Sure,
anyone.
definitely.
And this is our job is even remotely, virtually, we can try to assist and even collaborate with all the other facilities, hospitals, doctors. Our job is to educate and learn at the same time, because we are here. Learning is a never-ending process. I learn from patients way more than I learn from books, and I want them to know that it's a mutual respect and mutual I would say interest to try to get the patients the best outcome.
Right, sir. Thank you very much, doctor. Thanks for your time.
Thank you. Bye-bye.